I would like to invite Dr. Saraswat, who, as I introduced earlier, was my gastroenterology colleague at SGPGI for more than 3 decades. In fact, he joined SGPGI even before I joined SGPGI. He was one of the founding faculty members of SGPGI, and he has served the SGPGI for more than 34 years. And when I moved to Jaipur, I somehow coaxed, motivated, requested, whatever you want to say, to him to move to Mahatma Gandhi Hospital. And his moving to MGMCH has been a big boost to our transplant program particularly, and the Center for Digestive Sciences. So he is going to chair this session, and the speaker is Shalin Agarwal, who is now working at Max Saket as a important member of the team of Dr. Subhash Gupta. So over to Dr. Saraswat.
Thank you, Vinay. Am I audible?
Yes, please. Yes.
Thank you for that introduction. And it's been a great 2 years since I retired from SGPGI and joined Mahatma Gandhi in setting up our liver transplant work. It's been very satisfying and rewarding. And I'd like to congratulate Vinay on introducing this topic while he's been doing pioneering work with the Jaipur Surgical tutorials and the Jaipur Surgical Festival. Starting this program with LDLT, I think, is very appropriate and being done at a time for the audience. Similarly, involving the SGPGI, SG Surgical Gastroenterology alumni, I think, is an excellent idea and provides a wonderful forum. Maybe we can rope in the gastroenterology alumni also at some time as we go along. And it's great to welcome Shalin. Shalin has been with us at SGPGI during his training period, and subsequently we have come across and crossed our paths repeatedly. Today is one of the leading liver transplant, LDLT liver surgeons with the Max group of hospitals, which probably has one of the largest, if not the largest, number of liver transplants happening currently. Now, he's going to talk to us about indications and the LDLT in the setting of chronic liver disease and acute liver failure. An extremely large topic, and I repeatedly ask Vinay, I mean, you're clubbing these huge indications in a 15-minute talk. Well, Shalin has his work cut out, so I will not take too much of his time. Maybe you could illuminate us more on the acute liver failure aspects also, which is something that is not very commonly seen by most surgeons and which now is a prime indication. Of course, the entire gamut of chronic liver disease is the bread and butter for the transplant programs everywhere. So without further ado, I request Shalin to please take over and start his talk. Thank you.
Thank you, sir. Am I audible?
Yes, you are clearly.
So, thank you, Professor Kapoor, and thank you, Professor Saraswat, for having me in this, I would say, a novel idea of this Jaipur Surgical Tutorials. And I think it's a great idea, as you already mentioned, that Sir has included his previous students as the faculty and the presenters in this wonderful topic. And the brief allotted to me today, as you rightly said, it was a vast topic. And actually, I messaged to Sir that can we cover in 15 minutes both CLD and like it's covering the entire hepatology, which you take 3 years at least to graduate. So I'll try my best for that. So I'm sharing my. I'm getting host has disabled screen sharing.
Just a minute. Let me call him and share. Shalin, it is because you have logged in with Nirja's ID.
Actually, sir. On my laptop,
he's doing it.
Not updated. Sorry for that.
Just wait for a minute. Actually, I'm very sorry to the rest of the delegates because somehow more than 100 people are not able to join, and there are a lot of people waiting in wings, but we've sent them the YouTube link because it is being transmitted live on YouTube also. Himanshi is trying to get it sorted out. Yeah, now you are the co-host.
And I guess the recording will be available to everyone.
Yes. She's recording. We'll put it on the JST website.
So coming back to the topic allotted to me today is to talk in brief about chronic liver disease as well as acute liver failure. And to begin with, let's go back to the basics. So what is chronic liver disease? What is the underlying pathophysiology? And those who are surgeons may not be like them, taking them back to their MBBS days. So it is basically defined as a continuous and progressive process of hepatic fibrosis. And what is hepatic fibrosis? Is actually the deposition of extracellular matrix produced by the hepatic stellate cells in response to chronic liver injury, which is usually a continuous kind of injury. And actually, once the process sets in, even if you remove, the process does continue, though maybe at a slower rate, as has been shown in cases of hepatitis C virus infection, where despite antiviral treatment in many patients, the damage tends to continue. And this damage leads to architectural distortion of the liver. And as we all know, that it is the liver architecture which is actually responsible for the proper functioning of the performing all the hepatic functions. And once there's architectural distortion, there is sinusoidal hypertension, leading to the most important feature of cirrhosis, that is development of portal hypertension, and subsequently parenchymal dysfunction. And then there is subsequent regenerative nodule formation. The rate of fibrosis that has been shown depends on etiology also, and it's been shown that it's quite fastest when you have a combined HIV HCV infection, and it's slowest when you have primary biliary cholangitis. So this is just one anecdotal point that I wanted to mention. Etiology, we are all aware, commonest still being viral hepatitis, although now close in this race is alcohol abuse disorders, especially in from the urban areas. We are getting more and more patients of alcohol abuse disorder, as well as NASH, which stands for non-alcoholic steatohepatitis, because of the rampant use of alcohol, as well as the high prevalence of obesity and diabetes in our country. But still, because viral hepatitis, the older generation still carries a high load of hepatitis C and especially hepatitis B. So we still continue to see these cases in good numbers. And then there are some uncommon causes like polystatic liver disease, which includes this group of autoimmune hepatitis, primary sclerosing cholangitis, PBC, etc. Then veno-occlusive disease, and then a lot of metabolic syndromes. I would just rush through the slide because everybody knows. And this lower part, I have quoted the incidence from India. Professor Vijit Chaudhary from Kolkata published recently in 2022 a good epidemiological study, where it still showed that in India, the prevalence of hepatitis B varies from 18 to nearly 50%. Though alcohol is increasing and NASH is increasing, and from urban centers, the studies have shown up to 43% prevalence. And continuing with the epidemiology part, when we look at the global burden, so India is responsible for around 18% of the nearly 2 million deaths that occur worldwide, and that can be directly attributed to chronic liver disease. And when we look at all the deaths reported and recorded in India, 2.1% are due to cirrhosis and its complications. And in these bar diagrams, it has been shown that cirrhosis, even over the years, actually, the numbers have slowly crept up. Although in some Western countries, the mortality from cirrhosis has gone down because of the lower incidence of viral hepatitis and now availability of the treatment for hepatitis C as well as BDE. Excellent treatment. So nearly 200 per million deaths were reported in 2016 from India, the deaths which were attributable to cirrhosis and its complications. So the clinical manifestations, again, this is just brushing off our previous understanding of cirrhosis. The clinical manifestations are basically because of two pathological developments in cirrhosis. One is portal hypertension. And what is clinically significant portal hypertension? When the portal pressure is more than 12 millimeters of mercury. And as a result of this clinically significant portal hypertension, you can have esophageal gastric varices, hemorrhoids, epicnodusae, ascites, and hypersplenism. And on the second part of this pathophysiology is hepatic insufficiency itself. That is parenchymal dysfunction, which leads to jaundice, coagulopathy, that is loss of synthetic function, then hepatic encephalopathy because of the bypassing of the portal blood to the brain, and the loss of metabolism of estrogen leads to features of hyperestrogenism, especially gynecomastia, and then renal insufficiency and subsequently other organ failures. So what are the complications? The complications arise as a result of these clinical manifestations. So it can be in the form of massive GI bleed, which is one of the very dramatic presentations of decompensated cirrhosis. Then you can have hepatic encephalopathy, a healthy person suddenly falling into a coma. But these patients are very prone for infections, especially spontaneous bacterial peritonitis and tuberculosis. The incidence is up to 20% in some of these studies, especially from the developing countries. Then a common other organ complication is renal insufficiency. Actually, the liver and kidney go hand in hand. And then frailty, development of hepatocellular cancer, and then a syndrome of acute and chronic liver failure are all associated complications of decompensated cirrhosis. Evaluation, again, the basics, a good history and physical examination can never be replaced. Blood parameters, I have mentioned. Radiological, you need to get an ultrasound, transient elastography to see. It is more useful in early cases, and then in fully developed cases, you need to get cross-sectional imaging in the form of a CT scan or an MRI to look not only for the liver morphology, but especially for the development of hepatocellular cancer. Cirrhosis actually is a good soil for the development of cancer. You see very few cancers in normal livers. Most of them of the HCCs arise on a background of cirrhosis. Then you need to do a Purgy endoscopy if you want to do primary prophylaxis of the esophageal varices. And then to complete the list, invasive tests like HVPG and liver biopsy are there, though the role is still questioned, though HVPG is helpful as has been shown in the papers. Management basically can be divided into parts. The foremost is the treatment of underlying etiology, especially as I mentioned earlier, that viral hepatitis still constitutes a significant percentage of this burden of chronic liver disease. And so now we have very effective antiviral treatment, especially for hepatitis C, what we call the directly acting antiviral agents. And the antivirals for hepatitis B have been available for some time. That mainstay are entecavir and tenofovir and lenalidomide. Alcohol abstinence, it is, I would say, the only treatment, if I may say, that's the treatment for alcohol abuse-related cirrhosis. Because we have seen in our practice that many of these decompensated patients do improve just by abstinence. Then treatment of metabolic syndrome when you have NASH, and then steroids have been recommended in autoimmune hepatitis. For Wilson's disease, you have chelating agents, zinc therapy, and then hepatic vein venoplasty or stenting in Budd-Chiari syndrome. So these are some of the management strategies short of transplant when you have patients of chronic liver disease presenting to your OPD. Mind you, not all patients CLD should not be equated with transplant. See, transplant is the treatment of choice for end-stage liver disease, just like kidney transplant is the treatment of choice for end-stage renal disease. But many of, I would say majority of the patients are not end-stage. They are patients of cirrhosis, which may be compensated or decompensated. And so one should keep in mind that medical management or non-invasive management goes a long way in treating these patients and providing them with a good quality of life. And even I would say to the extent of avoiding transplant in some of these patients. Then you have treatment of complications. We all know that GI bleed can be managed pharmacologically, endoscopic management, TIPS, and then esophageal devascularization is for a historical interest. But mainstay is esophageal variceal ligation and pharmacological measures. And when everything fails, TIPS or placement of stents like LS-DELA stent can be a life-saving procedure. Ascites, the treatment is sodium and fluid restriction, use of diuretics, albumin infusion, and then large volume paracentesis. TIPS also is a good treatment modality in patients who present solely with ascites as a decompensation with good hepatic reserve. Renal insufficiency, you have to try to treat the underlying cause, which in many cases may not be directly hepatorenal syndrome. It could be pre-renal, post-renal, infection related. And when you have classical, the term HPS itself is not used very frequently. What we call is acute kidney injury. And you have to differentiate it from other causes. But when it's directly related to the liver dysfunction, that is when it's truly an HPS, then you have modalities like vasoconstrictors like terlipressin, alpha agonists like midodrine, octreotide, and albumin infusion for treatment of renal insufficiency. So I'm quickly rushing through. We can have a question answers if the participants or of this meeting have any questions related to these slides. Continuing with the treatment of complications, hepatic encephalopathy is a major complication or decompensation, and you treat it by giving lactulose. It not only acts as an osmotic laxative, it also acts by converting the ammonia in the gut to ammonium ion, which is subsequently then excreted and not absorbed into the bloodstream. And then rifaximin is an antibiotic, which helps in reducing the load of the gut microbiome, and thus reducing the ammonia production. And then, of course, you have to treat the underlying precipitating factors such as GI bleed, dehydration, infections, and electrolyte imbalance, which all can precipitate hepatic encephalopathy in a patient of chronic liver disease. Treatment of spontaneous bacterial peritonitis is basically broad spectrum antibiotics and albumin infusions. Pruritus is a very important presentation in patients with polystatic disease, especially primary biliary cholangitis, where bile salt raisins like cholestyramine have been shown to have a role. Then cholerectics like ursodeoxycholic acid have been used, antihistaminics and rifampicin, etc. So now coming to end-stage liver disease, and as has been mentioned by Dr. Balchandran in the previous talk, so liver
You
transplant.
have about 3 more minutes, please.
Oh, sir, it's very So liver transplant is why liver transplant in ESLD, because once you have complications, the 1 year survival goes down drastically, and post liver transplant survival is at least to the tune of 85 to 90%. So the probability of dying from the complications should be more than that of transplant, and therefore you offer transplant to these patients. And this is another graph which shows which has correlated the MELD score with mortality. And so once the MELD score rises above 25, there is the exponential increase in mortality, and therefore again transplant is indicated. So if I would say who needs a liver transplant, presence of irreversible liver disease and life expectancy of less than 12 months with no effective medical or surgical alternative to transplant. And then we have the child score, the MELD score as our scoring systems, which give an objective. Although child CTP score has subjective components, but MELD score is and lately since 2016, it's the MELD sodium that has been used for grading these patients. And any MELD score above 14 or a CTP score above 9 is a fair indication for offering liver transplant to these patients. Other indications being hepatocellular carcinoma within the accepted criteria, whether it's the Milan or the UCF, and then acute liver failure. So this is just a cartoon showing what are the Milan and the UCSF criteria. Due to the paucity of time, I would skip. Then a few slides about acute and chronic liver failure, which is a very hot topic for the last couple of years. Basically, it's defined as a syndrome in patients with acutely decompensated cirrhosis, which is associated with high mortality, 28 mortality. So it's just not plain simple acute decompensation of cirrhosis. It has been because the mortality in that situation is not that high, to the tune of 30 to 50% as it is in ACLF. And it is characterized by 3 factors. One, it develops in close association with the precipitating event, usually a systemic infection, which leads to intense systemic inflammation and association with one or more organ failure, which may be hepatic as well as extrahepatic. So the presence of organ failure and intense systemic inflammation is the hallmark of ACLF. And as the grade of ACLF goes up, the mortality goes higher, as has been shown in the graph on the right side. So this is the pathophysiology. You have a precipitating events leading to the production of inflammatory inducers, which lead to severe systemic inflammation and oxidative stress. And then there's an activation of immune-mediated tissue damage, leading to one or more organ failure and leading to acute and chronic liver failure. And there are various definitions of acute and chronic liver failure. I won't be going into the details. The one which we have been using in India is the Parsel definition or the Easel-Cliff definition. And basically, the definitions differ in various ways depending on at what point you are picking up the patient. So while a Parsel includes only liver failure as a qualifying criteria for ACLF, in the Easel classification, you need to have both hepatic and extrahepatic organ failure, while the North American definition includes extrahepatic organ failure. So basically, these definitions differ in terms of the time point at which you are picking up your patients. A Parsel picks up these patients early, while the Cliff definition picks up them somewhere in midway, and the North American definition picks up when they're very late, when they've developed multiple organ failure. So people purporting or supporting these definitions have their own points in favor and against using these definitions. So I think I would skip these. This is another topic in its own. Principles of treatment. You have to treat the underlying cause, which is very obvious. These patients often are hemodynamically unstable, so they need cardiovascular support in terms of vascular expansion and iotronic support. Hepatic encephalopathy has to be treated on the lines, as I mentioned previously. And most important, you have to treat the organ failure. So one of the organ failures is the hemodynamic instability. Other most common organ failure is the kidney failure. Again, the principle of treatment consists of withdrawal of diuretics, volume, albumin, terlipressin, and then there is a very important role of renal replacement therapy in these patients. And of course, liver transplantation has been a game changer again for these patients of ACLF who are critically ill. And though the results of liver transplant are less as compared to liver transplant for the garden variety decompensated chronic liver disease, but still you can achieve a 1 year 80% survival in patients of ACLF grade 2 to 3, which otherwise without transplant would have a mortality to the tune of around 60 to 70%. Now coming to acute liver failure, this is the last part of my presentation, and quickly again going through this, although Dr. Saraswat had asked me to spend some more time, but I will try to do justice. So it is basically defined as a syndrome of acute and abrupt and severe liver injury leading to coagulopathy and altered mentation, which progresses rapidly within days to weeks. The hallmarks are that it's associated with high mortality. In the 80s, 90s, even to up to 2000, the studies were showing that mortality could be as high as 70 to 80%. But lately, with the improvement in, I would say, not transplant, the improvement in the ICU care, better medical management and judgment when to transplant and when not to transplant. And I'd like to spend a few minutes in the question hour and how we decide in choosing these patients for transplantation has made all the difference. And now you can actually save nearly 70% of these patients. So mortality of 80% has come down to around 20 to 30%. And it is the only indication for an emergency liver transplant. All other liver transplants can be elective. I'm not talking about DDLT from the recipient's perspective. So causes of ALF vary widely between the Western and the Eastern hemisphere, while acetaminophen and drug toxicity is the most common precipitating factor for ALF in the West. In our countries, especially South Asia and even in the other developing nations, it is the viral infections, especially hepatitis A and hepatitis E. And that is very true because we have been continuously receiving patients of ALF. Children, it is hepatitis A, while in adults, it's usually hepatitis E. Drug-induced is much less common, and it's usually CAM, which is responsible for ALF, which we may actually call subacute liver failure, which is the most common etiology or precipitating cause of acute liver failure in our country, hepatitis E and A. And when we look at the clinical features, so besides coagulopathy, you have hepatic encephalopathy, you have hemodynamic instability, pancreatitis can be associated, adrenal insufficiency, renal failure. Patients of subacute hepatic liver failure may develop portal hypertension, that we have seen that the livers often become cirrhotic with ascites and development of varices. Systemic inflammatory response, so high catabolic state, and then you have bone marrow suppression. These patients, infection is the major killer in these patients. And liver, we know that there is loss of synthetic function in terms of coagulopathy and jaundice. And then lung injury, respiratory failure is another major killer in these patients. Numerous prognostic models, the first have been proposed. The first, which became very famous, was by the O'Grady from King's College and goes by the same name, that is King's College criteria. But actually, the King's College criteria were more for that acetaminophen toxicity because that was the most common indication of acute liver failure in the United Kingdom, though it has been modified subsequently for non-acetaminophen related acute liver failure. But what we have been using lately is the one proposed by the AIMS group, and that is the ALF early dynamic model, where they have included factors such as hepatic encephalopathy, INR, ammonia, and serum bilirubin, and they measure it in a serial dynamic way at presentation, then 0, 1, 2, 3 days, and any value more than 4, despite your best medical management, becomes an indication for a liver transplant. That is a failure of medical therapy. Though one cannot say that you can go only by any of these prognostic models, whether it's the King's College criteria or the Clichy criteria or the ALF early dynamic model, the MELD score or the SOFA score. They are just helpful. So you have to have a gamut of various parameters in your decision-making algorithm for deciding for medical management versus liver transplant in a patient of ALF. The major problem in such patients is that the time is of paramount importance. And once you have irreversible brain damage, and we have burnt our fingers in the past when we did a liver transplant, but the patient became vegetative. So I still remember 2 cases, but that was many years back while we were growing in our experience. So all these prognostic models are useful, but none of them is a standalone factor for decision making. This is a very busy slide.
I think we need to
Sir, this is the last two slides, sir. So basically, the investigations can be divided into three categories. When you receive a patient of ALF, you have to confirm the diagnosis, because in our country, dengue, falciparum malaria, lactospirosis can have the same presentation as acute liver failure, and the treatment may be totally different. These patients may survive without transplant. Then you have to determine the etiology and then investigations for determining the prognosis. And the last slide is about the management. So early referral, if you have a patient in a peripheral center, early reference is of utmost importance, because time is running out for these patients, and these patients can develop cerebral edema with irreversible brain damage at a great speed, which even the treating doctor may not, or the physician may not anticipate. So early identification or early diagnosis, early admission to ICU. General care consists basically preventing patient from developing hypoxia or hypercarbia. Fluid and electrolyte management. So avoid Hartmann's and Ringer's. Balanced salt solutions should be given. Managing hepatic encephalopathy, don't use lactulose or rifaximin as you use in ACLF or chronic liver disease. Mechanical ventilation becomes important when you have patient passing into grade 3 or 4 encephalopathy. Then the management of cerebral edema and the raised ICT is the cornerstone of medical management of ALF. For that, you need patient to be managed in a dark room with head elevation, then the use of hypertonic saline, mannitol, then correcting acidosis. Correction of coagulopathy is of least importance. These patients usually don't bleed, so it is a fallacy of that you should give FFP. It is more harmful than good. Don't give any FFP or cryo or platelets unless the patient is actively bleeding. Renal failure has to be treated aggressively, and it has been shown, and in our own experience, early initiation of renal replacement therapy has been helpful in stabilizing these patients while you prepare for transplant. Many patients even in reversing. Basically, ALF is a self-limiting disorder. It's basically you have to provide time to the patient, bridge the patient so that the liver regenerates. And this is my last slide. Infections, the major, besides irreversible cerebral damage, the other reasons for mortality in these patients are multi-organ failure and infections. So you have to handle the kidneys by renal replacement therapy, mechanical ventilation for encephalopathy and lung injury, and then broad spectrum antibiotics for treatment of and as prophylaxis for infections. Then antioxidative measures like use of N-acetylcysteine. And of course, nutrition should not be left behind. It is an often under-stressed mode of treatment. So nutrition should be started as early as possible. And if the patient is been diagnosed in a peripheral center, please refer these patients to a specialized liver unit. That make all the difference between life and death. So because of paucity of time, I would like to wind up my presentation here. I've missed many points, I know, but we can discuss them in our question answer session. Thank you very much for the time, sir.
Yeah, mistake is mine that I gave you such a broad topic. Maybe I should have clarified to you that I wanted you to deal with these two conditions as the indication. But anyway, so we have 5 minutes. There are some questions in the chat, and Dr. Saraswat, please take over.
Yeah, I think I must compliment Shaleen on doing a super fast and a very good overview and a very competent job that any hepatologist would be proud of compressing all this information in bare 15, 16 minutes. Shaleen, I think before we take up the questions in the box, a couple of points that I'd like you to think about. In your very early slides in the etiology, you said viral hepatitis is still the most common etiology, which is what Abhijit Chaudhary's paper 3 years ago from in the CGH says.
Yes, sir.
Do you think is it not a reflection of the fact that alcohol is underreported in most databases, and while it is in practice probably one of the commonest conditions that we are encountering in all hepatology ICUs and even among transplant patients, I think for various reasons, including reimbursement and insurance and so on, it often does not get shown in black and white and it's being underreported. What are your thoughts on that?
I totally agree with you, sir. And in keeping our data, and you rightly said, because of insurance reasons, we have often don't write alcohol. It is the most underreported. In our own data, 35 to 40% over the years, the reasons, indications for liver transplant have been alcoholic liver disease. And NASH is number 2. And since we stopped getting patients from Pakistan, the hepatitis C has gone down dramatically because that was rampant there. We do get some patients from Punjab or occasionally from the Northeast. Yeah, actually, hepatitis B patients are still more in number compared to hepatitis C, especially after the introduction of DAs. But I would totally agree that alcohol is a very, very underreported etiology of decompensated liver disease.
I think there are a couple of other points on the ALF that I'd just like to bring up. I think you've done a very proper representation that it is the advances in the ICU care and our better understanding that have dramatically changed the outcome in ALF. But however, for cerebral edema, I think now one thing I'd like to point out and maybe emphasize, I don't know whether you agree with that or not, is that mannitol should be strongly discouraged in these people. Getting their serum sodium up to normal, managing them with the sedation, ventilation, etc. CRRT, early introduction that you spoke about, is probably a very crucial part of helping to manage the cerebral edema. But mannitol, unless you have the serum osmolality monitoring available, and you should not cross 290 to 300 osmoles, it's counterproductive using mannitol and aggravate the renal injury.
Again, sir, I totally agree with you on that point. I just mentioned mannitol because even the INASL guidelines mention it. But in our actual practice, we have hardly used mannitol for a simple reason, because many of these patients are actually having renal dysfunction. So you cannot give mannitol these patients. And as you very rightly said, that correcting the hypercarbia and then raising the sodium. So we make all efforts including hyperuse of hypertonic saline to raise the sodium to the level of around 150 milliequivalents. And then early initiation, I again reiterate, you have also said, and I would again reiterate, that early initiation of renal replacement therapy can work wonders. It can make all the difference between transplant and no transplant.
Absolutely. So maybe you could take up something from the box now. You have a lot of questions in the...
Shalin, there are a lot of questions. So quickly, if you can finish with all of them.
Okay, sir. So how would you manage...
I will read the first question because it has come to me directly. Dr. Tushar wants to know, please explain about timing of transplant in autoimmune hepatitis.
So autoimmune hepatitis actually can be managed medically for many, many years, and the indications for transplant are no different from any other disease. So autoimmune hepatitis, actually I mentioned that because autoimmune hepatitis is one of the diseases or etiologies of chronic liver disease where you can manage these patients without transplant medically for a long time. But they have to be under the close follow-up of a hepatologist. And then at the same time, the medical management should not be dragged on for too long, because steroids and the use of antimetabolites can actually make these patients very frail, and these patients can become very prone for infection. So the indications remain same. You have to use the same MELD scoring system for these patients. And once you have, despite the best medical management, a MELD score creeping above 14, 15, maybe reaching up to 20, you should definitely offer transplant to these patients. Although these patients have problems. So because autoimmune hepatitis is a disease which is known to recur post-transplant. So close follow-up post-transplant is also essential, but the indications for transplant for AIH are no different from indications or the criteria as for other diseases.
Please take these questions from the chat, Shalin, one by one.
Yes. So how would you manage varices in liver transplant patient before and after LT? So after LT, you don't have varices. Even if you have varices, because you have taken care of the portal hypertension, they don't bleed. So it's not that immediately after transplantation, the varices would disappear, but they tend to get decompressed, and that is all what you want. And pre-transplant, the indication remains the same. That is, it depends on the timing. If it's an imminent transplant, we won't do an endoscopy, even if it's grade 3 varices in the past endoscopy reports of grade 4, just because many of the times the EBL itself can induce infection in these patients. So if you are going to transplant a patient within a week or next 3-4 days, you won't bother to ban these varices. Otherwise, if you have a waiting period, then please go ahead and ban the high-risk varices, as has all the endoscopists. So next question, sir.
ACLF, ALF grading.
No. In the previous one, there is a question on octreotide and terlipressin.
And next question is, what is the role of octreotide in renal insufficiency? So yes, if you go by the North American guidelines, so the MOA protocol, which is midodrine, octreotide, and albumin, because terlipressin is still not FDA approved. I think recently it has been approved, but
Yes.
till in all the studies they have used this combination of midodrine, octreotide, and albumin. Standalone octreotide is not very helpful, but these three, a combination has been shown. Now it's a controversial topic. There are studies comparing both Turley, and in studies from the East, the Turley has been shown to be superior, but the Westerners may not agree to that. So next question is how is ACLF and ALF graded? So you, as I mentioned briefly in those in one slide, you have three definitions. That is the apostle, the Cliff-Sova scoring system, that is the EASL definition, and the North American. And the grading is, you have the ARC score, then you have the grading based on the organ failure by the EASL, where you grade, you have taken the various Cliff-Sova scoring system, and then you grade them as ACLF grade 1, 2, 3. And this is in brief the grading. And for ALF, it's not the grading, it's basically prognostication. So you have the various prognostic models such as the King's College, the Clichy, the SOFA, the MELD. And what we use is the ALF early dynamic model for prognostication. So there is no separate ALF grading per se, though you have a grading for ACLF indeed. Next. Cliff-Sova score, yes, it is a very widely, and I find it very objective. So although in India, we tend to use the ARC score, but now actually I'm doing a study where I'm prospectively comparing the impact of the ARC as well as the Cliff-Sova score vis-a-vis the outcome of these patients in a busy transplant center. Although there are studies to that effect, but I'm making a direct comparison. In the short number of cases, few cases that we have done, I think. Although in India, we tend to use. So I think the Cliff-Sova score scores better, but that is, I think, just an observation. We have not analyzed our data. We are still collecting data. Stem cell in ALF, I don't think there is any role. ALF is an acute emergency condition. There is no role of, you don't have that much time. You have to manage these patients as an emergency in ICU. You can lose these patients very quickly within 24 to 48 hours. So decision making is of paramount importance. You cannot do all these kinds of therapy till date. In future, I don't know what will come, but there is no role. A strict, clear cut no. What would be the best time to transplant on a patient with ACLF? Well, you don't transplant a patient of ACLF immediately, first of all. You have to grade these patients. And actually what we have seen is that ACLF grade 1, according to Cliff-Sova, is no different from a run-of-the-mill decompensated CLD. You can go ahead, stabilize these patients and just go ahead and transplant. However, the ballgame totally, the scenario changes totally when you move into the higher grades of ACLF, like ACLF grade 2 and especially 3. You have to be ACLF again 2 and then 3. You have to spend some time, give these patients some time in the ICU and manage them medically. Actually, you can bring down the ACLF score in many of these patients. Simply, the driver of ACLF in many of these patients is the renal dysfunction, hemodynamic instability, which can be corrected. Again, all organs do not score same, although the scoring system does give them the same point. What we have seen is that respiratory failure is the biggest killer in these patients. So if the PO2 FiO2 ratio is less than 200 or 150 as per the various definitions, then you should be wary of transplant in these patients. And if you have to transplant them before they go into the spiral of irreversible respiratory failure. So ACLF grade 1, don't wait, go ahead. ACLF 2 and grade 3, try to improve these patients and see if they are on an improving trend. You don't wait for the creatinine to normalize. You don't wait for the blood pressure to completely become normal. Low dose inotropes, you just have to see the trend. Once they are on an improving trend, the kidneys have opened up, go ahead and transplant them. They will recover. But if
Shalin, I think we'll stop. We'll take the remaining 3 questions if people stay on even after the last session. So okay. I think because we need to go with the next. Dr. Saraswat, any closing remark?
Not at all. I must compliment Shalin on covering the topic very well in the very limited time he has had. And I think that calls for him to do a separate session on the next LDLT program that you do, concentrating only on ALF and its management. Wonderful. Well done, Shalin. Thank you.
Thank you, sir. It will be a pleasure.
Thank you, Dr. Saraswat. Thank you, Shalin.